All right, folks, it's 9:40. Let's get started. So, good morning and welcome to Friday Chalk Talk. Today we've got our second medical ethics case discussion, and I've got three guests to introduce to you today. So first, we have Linda Fisher. She's a licensed clinical social worker with the inpatient palliative care team at Advocate Christ, where she also serves as serves on their ethics consult service. So welcome, Linda.
Thank you.
Second, we've got Dr. Ken Chow. He's a third-year family medicine resident with Advocate Christ. And Ken has a master's in bioethics, and he hails as a native Chicago Southsider. Welcome, Ken. And third, we welcome back Dr. Clint Moore, who's a bioethicist with Advocate, and for whom I am a little bit jealous because he got to study under my favorite ethics author, Edmund Pellegrino from Georgetown. And so welcome, Clint. So today's format is really going to be two parts. Linda and Ken will present the case, which will be followed by open discussion for everyone. And I think my final remark is just to comment that today's case, while based on real experiences that will sound familiar and that we probably have all seen, the details have been omitted, changed, added a little bit to protect patient privacy. So with that, thank you guys all for being here. I hope you enjoy today's talk. And Linda and Ken, I will hand it off to you two.
Great, thank you. And thanks everybody for being here and joining us today. So what I'm going to do first, I'll read the case for you so that you can get familiar with some of the things that are of interest here. And then I believe Ken is going to talk about some of the overall themes of what we're going to discuss. And then we kind of put together some questions for discussion. So we'll kind of go from there, and please feel free to join in when we get to our discussion. So the patient is an 80-year-old woman with a history of metastatic breast cancer, coronary artery disease, stroke, and COPD. She has had 2 recent cardiac arrests with subsequent anoxic brain injury. Patient was followed by the palliative care team during several admissions. Prior to initial admission, she lived in her home with care provided by her son. She assigned her son as healthcare power of attorney. Other family members reported concerns for care in the home. There was a report made to Adult Protective Services for possible neglect. Son agreed for patient to transfer to a subacute rehab after that admission, so she did not return to the home. Son retained the role of healthcare power of attorney. The patient stated several times in the past, when she was able to express her wishes, that she wanted DNR and comfort-focused care. The son consented to hospice during an earlier admission, although brought her back to the hospital when she became symptomatic, revoking hospice. He stated he was not comfortable having the patient die at home. Numerous discussions were held with the son, during which staff brought up patient's expressed wishes for comfort focus. Son was not persuaded to consider any limitations to care, stating he wanted patient to live. He shared that he believed she did not receive supplemental O2 at the time of her cardiac arrest, and that her brain injury was for unnatural reasons. He wanted to give her time to recover. It was explained that the anoxic brain injury was likely related to the cardiac arrest itself, and that it was not expected to improve. An ethics consult was placed by the attending doctor to address son's continued refusal to honor patient's wishes. Staff believed resuscitation would not be in her best interest. Review was done by the ethics team with recommendation that unilateral DNR be put in place. The ethics committee met with son by phone. He was informed that unilateral DNR would be put in place, and the reasons were outlined. The son stated that if the doctors believed the patient should not be resuscitated, he would be okay with that, although he would not be the one to request it. Unilateral DNR was entered for patient. Son declined to discuss hospice care for her. The patient remained at hospital for several days, during which she continued to decline. Patient was treated with comfort measures and died while in hospital. Dr. Chow,
Yeah.
I think.
So, as we think about, as you guys think about this case, some of the themes that we think about in ethics, clearly the 4 basic principles are quite obvious here, patient autonomy, and when it crosses over to surrogate decision-making, the goals of beneficence, non-beneficence, and of course, justice in regards to, allocation of resources. for us, one of the big things is, is our duty to the patient, or is our duty to the surrogate decision maker once the patient cannot make decisions, and depending whether we follow legal terms, moral terms, that can differ. And of course, there's our role in healthcare to do good and avoid harm. Well, to do good and avoid harm can differ based on our context. For this patient, it was more comfort care. And if we were trying to do it in terms of the goals of the surrogate decision maker, it might be more aggressive care. And so it kind of does differ depending on which we follow. And for the physicians themselves and their own personal views, it might be either end, it could be somewhere in the middle and along the spectrum. And, I haven't practiced as long, but we think about like the history of autonomy. Before, medicine was really paternalistic, maternalistic, and now the pendulum's kind of switched over to the other end where autonomy is kind of the biggest thing we focus on right now. And that is valid, but I wonder, at what point does the pendulum kind of swing back over to maybe 80-20, 70-30, more paternalistic and / autonomy? And then the other thing we can think about is kind of withholding care versus withdrawing care, right? Is there a difference when we decide not to place a peg to someone and versus pulling a peg to someone? Kind of ethically, we do kind of argue there isn't much difference, but for patients, for many physicians, healthcare professionals, we do definitely feel like there's a difference. We feel like there's a difference between passively harming someone or passively helping them get to the end of their life and actively doing it and causing harm. So just things to think about for this case.
So to get this started, I wanted to do one of the questions or present one of the questions that we discussed that I think is kind of at the heart of this. So I'll start there and then we'll kind of start our discussion and hopefully everybody can kind of chime in and we'll go from there. What is the impact or importance of patients' request for DNR and comfort-focused care when they are no longer able to make decisions? Is their decision maker compelled to comply with their wishes?
So I'll be happy to at least start off a little bit on this. It really depends on how the patient's wishes have been expressed, but I know Illinois does not. And I'm going to speak in some generalities about Wisconsin because I practice there, but the statutes are a little bit different. But if a patient has made a verbal statement, that is different than a patient making a statement in a power of attorney for healthcare. So remember that powers of attorney for healthcare in both Wisconsin and Illinois allow patients to set limits on their agent's decision-making power. So there's a section specifically on the Illinois side that if you have a patient who really wants that, I would advise them to fill out that section about limits. Then there's actually no legal way that the agent can override the patient's wishes. But in general, courts don't want to see this. They would rather folks work this out at the hospital.
Yeah, I think one of my first knee-jerk reactions was, are we approaching this case with the ability to really listen and allow ourselves the chance to learn that we could be wrong? Listening to the case, you're making a very clear argument that we know what this patient's wishes are, and maybe we're right, but maybe we are not. I mean, who's to say that this son doesn't know something about her that we don't know yet? And sometimes I think we find ourselves getting sucked into that trap of assuming that we're correct and we need to convince the POA of something that's different. And I know we all know this, but yeah, I think it bears saying again that resolution in most ethic cases, it comes from conversation, it comes from relationship, not about debating or proving who's right or who's wrong. So going into these cases and sitting down with the son and trying to understand where is he coming from, maybe there's something that we don't know.
I I guess I would just echo and reinforce that. Nothing really to add. First of all, thanks for presenting the case. I think it highlights well a lot of the issues we all deal with. But as Marty said, it's well known, it's simple, but we need to listen and then, just listen and be present in that. And then, as the saying goes a lot these days, words, conversations, the way we word it matters. The medical and scientific facts of this case and many other cases are pretty clear cut. And then if we look at the authority of the surrogate, it gets a little less nebulous, but a lot of times by jumping to a certain place, we inadvertently, I think, and unwittingly create extra challenges and conflict where, as Marty said, the listening goes a long way to see where they're at with fears, concerns, just whatever.
And I think that's one of the additional things I thought of too here is that when we're talking to the son, because he had concerns about her dying at home, that scared him. He had some idea of how she got this anoxic brain injury, and was there something they didn't do when they resuscitated, or something that caused that? Not that it was maybe just from having the arrest. So I think if we can talk to him about those things, that maybe we can help with that and help him understand and accept what's going on.
Linda, one other thing, and I think Martin brought this up in our last meeting, is that there is literature that at least sets forth that patients don't always object to their appointed decision makers making decisions that are different from their own wishes. In other words, the woman wanted this, but she may not have objected to her son making different decisions. We might not have been able to get at that because of her perhaps lack of responsiveness, but there is literature to show that a lot of patients with powers of attorney or surrogates say, well, that's, whatever. If they need to make a different decision, that's fine.
Yeah, so it kind of opens up to our, opening up our thinking about this and not make judgments on it, I guess, ahead of time or based on what we think should happen. We always look at things, we say, well, I wouldn't want this, or I wouldn't want my mother to have this, but yeah, just we need to open up our thinking process here.
Right.
The other point that I think is always important in these cases is the pace we move in healthcare, where we all feel pretty pressured to get to decisions and get things done and get someone to the right place. And having the patience to repeatedly talk to family members like this, I think goes a long way in building that trust and getting us to where we all need to be, which is a degree of comfort with the decision.
If a patient, when they are able to speak for themselves, if they request hospice and hospice services are started, and then they go home with their family, is there any issue with the family then revoking? Does this follow along the same lines? If they feel like for some reason they need to bring her back to the hospital, continue aggressive care, whatever, and revoking that, is there any concern there as far as this is what the patient agreed to and now that's changing? Or I guess there's an issue too of maybe he doesn't feel supported enough at home too. So we gotta kind of keep that in mind.
I would say you're spot on, Linda, and I would say, to state the obvious, there's a lot woven into there. Again, I think the same principles is to, listen and to see where they're coming from. But yeah, if we decide that, yeah, this is kind of a change, there's nothing magical that you can't revoke hospice and say, yeah, that's where we thought we were there at that point, but we've kind of changed, if that makes sense.
Why did they enroll in hospice to begin with? Some folks will enroll in hospice just to get home and get out of the hospital. Or do they really understand what they were signing up for? did they even have capacity? I mean, we often will question capacity when people don't agree with us, but if we're recommending hospice and someone just simply agrees, we tend not to dig so much as to why they want what they want.
And I wonder with some of these families, if they really understand what they're going to be dealing with at home, and are they really ready for that? Have we prepared them, or could we even prepare them well for what they're going to do when they're home with the patient?
As someone who works in hospice a lot, I would say, I think you're again spot on, but shame on the hospice if they haven't done that diligence, and some do and some don't, because the other part of that is if they think and it's constructed to them, there are the levels of hospice. So if the son is, not comfortable, there's both the respite option and there's the GIP option. Obviously, the respite's more for the caregiver, and the GIP is more if symptoms are truly uncontrolled from a patient standpoint. But I think you're right. In my experience, even though hospices say, yes, we always define what this is going to look like and how it's going to play out, I think often my experience has been, no, it does not.
Go ahead.
No, please go ahead, Linda.
Well, no, I have so many questions. We could be talking for a while. I'm trying to boil it down here.
I would just say, I'm curious, and perhaps it's the time crunch. I get it, but when we have patients who are going home who've maybe done acute rehab, and there needs to be things done by the caregiver at home, we invite those people in for like a week-long training, how to transfer your mom out of the bed into a wheelchair. And I wonder if obviously it's different during the pandemic, but if we could do that, if there are concerns about a caregiver caring for someone at home, have them come in for 2 or 3 days, do your mom's personal care, and that might have shown up as a red flag that, maybe it wasn't so much he didn't want her to die at home, although that could be an issue, but many times sons just have a difficult time caring, especially for their mom at home. So doing all the personal care that you need to do if they don't have resources to have a caregiver.
I think the reality is we get so many calls from home hospice patients who they all start with great intention, but then the burden of the physical care and the act of doing nothing as someone's coming to the end of life becomes really difficult for family members. Even if they're intellectually prepared, they're not always emotionally prepared. And I think that when we live this stuff all day, and it seems like, well, this is logical progression, but it's new for them. And I think we sometimes underestimate when we get people into hospice, how tough it's going to be to manage at home.
That's what I was going to say is sometimes, well, a lot of times families don't know what they don't know. And it's a fine line of trying to get them to understand what they're signing up for and not seem like you're trying to push them in one way or the other. But so that's always a difficult conversation. Are you really sure this is what you are capable of doing, without sort of weighing the whole conversation down with the nuts and bolts of exactly what that looks like? I typically go with the doing versus being, and the importance of being the grieving wife or the grieving daughter versus the doing, and getting yourself into the treadmill of doing, and losing that opportunity to just be with your mom or your loved one at the end of their life. And so sometimes that helps to move that conversation into without weighing down the nuts and bolts of, you really want to wipe your mom's butt, that kind of stuff.
So I wanted to just talk a little bit about the unilateral DNR, if we have a few minutes here. We imposed this on the patient, and one of the questions I had was that the son was not, he said, well, if that's what the doctor thinks is best, that's fine. I won't be the one to ask for it though. So I thought, is there any liability once we put that unilateral DNR? If he were to come back later after death, perhaps, and say, I really didn't want that. I didn't really say that and wasn't really strenuous about his acceptance of that. Is that ever going to be an issue? Or pretty much once the doctors have both signed that, then we're okay with it?
This is going to sound really cynical, but yes, there is always liability exposure.
Mhm.
So
Okay.
yes. But
All right.
in this particular case, I think there's an extra level. There's some precedents that would provide, I think, some reassurance. But yes, I think the very nature that a DNR, which is the main and the norm, is a bilateral agreement that this is where we're at, so to speak, is probably a safer situation than unilateral. But I don't know that it's way out there in left field either. I think it's just on the spectrum of risk, certainly higher from that standpoint.
And then does the unilateral DNR, and maybe this is a basic question, but does that imply then that we're going to be pursuing comfort-focused care for that patient? Necessarily? Not, no implication.
No.
Yeah.
And how interesting that the son was absolutely ready for the doctors to make his mom DNR, but he couldn't. It kind of goes back to that pendulum swinging towards autonomy, where we want patients to make all the decisions and take on all the burden, when really it should be a 50-50 decision, where the physicians are helping to make a recommendation and take some of that burden off of family members.
I think the other thing is, as everybody said, we should be listening, and especially be listening for those people who really just don't want to make that decision. They want you to make a recommendation that they can agree with or not object to. They just, there's lots of people in the world that just don't like to make decisions. And these are biggies.
And I think, if I look back at the case, which, I didn't know very well, to add an additional point to it, is that I think if we'd been more astute up front, that we would have seen or interpreted these kind of hesitation of the son as meaning more than just, oh, he doesn't care about this, or he's not being available, or he can't handle it. We have to kind of not just think we know why these decisions are being made by these folks. And maybe we could help them with that somehow.
Yes, and as we all know, and as Clint said, we all encounter family members like this that really are uncomfortable making those decisions. But back to your question, I think the fact that the son indicated he was okay if the doctors, to state the obvious, that just needs to be documented in the charting for the consult, that and if he sounds like he stated explicitly he was okay if the doctors did it, he just wasn't comfortable.
All right. Anybody else have any concerns or things to share with this?
If I could just answer your first question and your last question on your list, because I think those come up sometimes. And the first question, I think I can answer for both states. The last one, I'll just answer for Illinois. So does the healthcare power of attorney retain decision-making if a report has been made for possible abuse or neglect? Yes, because it's possible abuse. So a report has been made, Adult Protective Services will do an investigation. I mean, we had a case last month where they did an investigation, and the investigator actually came to the hospital and said, "You will not speak with the family at all. We are moving toward, we're asking you to petition for guardianship for the safety of the patient," which is what we did, because they will then join in the guardianship proceedings and say, "Your Honor, here's all this evidence." But many times these reports, it's not what we think it is, again. So a report is just that. It's a report. There will be some, either no evidence or some evidence. Is there a difference between the level of authority held by a healthcare power of attorney versus surrogate decision maker? In Illinois, absolutely. So a power of attorney has the right to do, really with almost unilateral authority, request a no CPR order, request comfort measures. In Illinois, a surrogate decision maker, per the statute again, must get approval from the physician. And technically, and I think I don't think I'm talking out of school here, we try to make this work for patients and families. The patient should, if we're moving toward a no CPR order or withdrawing death delaying treatment or life sustaining treatment, they should have a qualifying condition: permanent unconsciousness, incurable irreversible condition, or terminal condition, if they have a surrogate decision maker. So, and then last thing I'll say, I know I've talked a lot, and this is with all apologies to Dr. Chow, because I think it's part of the way we educate our residents these days. I always find the terminology withholding, withdrawing care to be a dangerous collection of words, because it implies to patients and families that we're not going to care for you anymore because we're going to withdraw it or we're going to withhold it. So I would always, go ahead and use the withhold, withdraw, but we're not going to do chest compressions and intubation. However, this is what we are going to do. But we'll always care for your mom.
Perfect. Beautiful last words. All right, guys. Thank you, Ken. Thank you, Linda. Thank you, Clint. Thank you, everybody, for being here. And we'll see you next Friday.
Thanks so much. Take care.
Thanks.
Have
Take
a
care.
great weekend.